This episode of EMS One-Stop is brought to you by Lexapol, the experts in policy, training, wellness support and grants assistance for first responders and government leaders. To learn more, visit lexapol.com. That's Lexipol.com.
This is just a conversation starter plus. And as long as we get to that point, then I think we're having a conversation about something besides response time, which means we're probably in a pretty good spot.
Hello and welcome back to another edition of the EMS One-Stop podcast. I'm your host, Rob Lawrence, and today we're going to talk about my and my guests' favorite four-letter word, and that is data. And I have enjoyed a good chat about data, and this time around we're going to talk about the 2025 ESO EMS Index. And to help me talk about that are my great friends, Dr. Brent Myers and Dr. Remle Crowe from ESO. Welcome to the EMS One-Stop podcast. How are you?
Great. Thank you for having us.
Doing great. Very nice to be here.
So to set this up, of course, the index is now published. It's live. You've already presented on it. I have to say, before we get into discussing the various measures that you've identified, that the report is very, very easy to read. The report is amazingly laid out. It falls off the page at you. And I encourage everybody, as soon as you've listened or watched our discussion, to go into the show notes, to download the report, to take it in and obviously look at the way it's laid out, and obviously which leads to actions, to-dos, and of course, performance improvement. So can you just sort of start off by talking about, the origins of the report and, really the sort of very bottom line up front, right? The key findings, and then we'll drill down into the actual findings themselves.
So I'll lead in just to give the overall, why do we do this thing? And, there's levels of data and evidence and ways that we want people to interact with them, right? And some of those are what I call, cocktail conversation, right? Did you know that 3% of patients create 16% of EMS volume? And then, you can have a conversation around that kind of thing. And then there's all the way up to a randomized, controlled, well-designed trial that's designed to influence care tomorrow. Like, we should change care because this evidence is so strong. The EMS index lies somewhere in between. And the goal of this is to be very accurate and transparent with the reporting, but to start a conversation about very important things that are happening within our industry. So it is with that we, number one, pick measures, and number two, retire measures once they've hit a plateau. And I think, I'll hand it over to Remle to give her insights as well. But I think the goal here is we're well above cocktail conversation, slightly below a peer review, and to enter into the industry conversation around that.
Absolutely. And our goal with this is to get folks to be curious about some of these measures. So it's a really great time to be in data. I mean, years ago when we were on the paper try sheet, and yes, I remember those days, it would have been really hard to measure some of these things that we're going to talk about today. It was much easier to measure things like timestamps. And so we tended to focus heavily on things that we could count and times, but because that's what was available. Now that we have electronic records at our fingertips, and now that we have integrated electronic records with hospital outcome data, we're able to ask and answer different questions and work at improving care. So like Brent said, every year we pick out a handful of performance measures and a couple of surveillance measures that we should look at as an industry and just talk about where we are at the performance, and then allow others to take that information back to their agencies, look at their own data, and hopefully decide whether or not within their own local setting this warrants an improvement project.
So you're right, we've come a long way, Remle, and looking back, it's actually been 14 years since I presented a session at the GEMS conference called Data, My Favorite Four-Letter Word, where we were trying to convince organizations you actually have information that you can turn into intelligence that you can use to make your practice better. And it felt then like an uphill struggle. So I'm so pleased to see how it's come on, obviously what EMS is doing. Now talk about the size of the database and obviously where you are drawing all of your information from.
Sure. I can start with a little bit of background on the ESO Data Collaborative. Is this really unique database that is direct result of a vision that our founding CEO had at the very beginning of establishing ESO. As he was building out this, he had the idea, well, why are we going to collect data if we're not going to use it to improve community health and safety? And so ever since day one, at the time that an ESO partner becomes an ESO partner, they have the opportunity to participate in this ESO data collaborative. Now, it is entirely de-identified, so we don't know who the agencies are, we don't know who the clinicians are, we don't know who the facilities are, and of course, we don't know who the patients are. That almost goes without saying, but we should say it, right? Everything is entirely de-identified in that sense. And so this has grown astronomically over my time at ESO. We are currently at over 3,000 EMS agencies and seeing over 14 million EMS records annually. And a large proportion of those, which we'll talk about as we get into some of the measures, are linked to hospital outcome data. So something that in my time in the field was truly a unicorn is absolutely not a unicorn anymore. It's almost common practice.
So we know from the NEMSIS database, there's about 50 million-ish records annually. So you're about a quarter of the load as your sample for the work that you're doing, which is an impressive number in itself.
Right. And I can't wait to dive into the repeat patient encounters, because we ask ourselves the question is, those are responses, and we've been traditionally response-based, but we're at a place where now we can be a little bit more patient-centered, as the EMS Agenda 2050 has challenged us to be. And it's very interesting to see how those numbers change when we start looking at unique incidents and then even at unique patients.
Do you know what? I'm glad you said EMS 2050. When it first came out, I looked at that, and bearing in mind, we maybe 5, 6, 7, 8 years ago, when I started to read the preface of that, saying, and it did some imagineering, let's call it that, where it looked to 2050, and we talked about the ability to talk to your watch and get the patient record from HIE down. I'm thinking, bunkum. We're moving there very, very rapidly now. And obviously, this what we're about to talk about represents that future as well. So I'm really, really excited. So let's jump in if we can. And obviously, you have a number of measures that we want to talk about. And metric number 1, pre-hospital analgesic administration for patients with long bone fractures. What can you tell us about that?
I'll set the stage really quickly because this is one of those issues in EMS that I say is probably the greatest whataboutisms I've ever seen. We didn't treat pain. Well, what about it wasn't really pain? Well, we didn't treat pain for this group of patients. Well, they live at a different proximity to the hospital than other populations do. Or what about this? Or what about that? And so the reason we pick this measure is, number one, we have verified hospital outcomes, as Remle was talking about. And so every patient in this measure had a verified acute long bone fracture in the emergency department. Unequivocally, these patients are experiencing pain. So it takes out this, well, was the abdominal pain real? How bad was the headache? All of which I think are important. And I'm not saying we shouldn't treat pain in those populations either. But the reason we chose this measure is because of its simplicity. You just can't argue that if somebody breaks their femur or breaks their humerus that they're having pain. They certainly are. And then I'll let Remle talk about the findings, but the reason we picked this measure was just to take a lot of the whataboutism stuff off the table.
So before you go into the findings, Remle, of course, this comes back to the layout of the report for the reader, that you are really coming up with, challenge, findings, and then some takeaways and some to-dos. And I think the way that it's laid out is really going to help the reader to really get into the meat and potatoes, as we'd say, of this issue. So sorry, Remle, do carry on.
Yeah, I think Brent did a great job laying out, as you mentioned, the challenge that we're putting forward, and we're taking away those whatabouts, what if, all the excuses to not act are now gone. And not only are these confirmed long bone fractures, we only included ones with a documented pain score. So EMS took the time to report a pain score, and that pain score was classified as severe pain, which we say 7 to 10 is severe pain on that scale based on some existing literature. And so, think to yourself, if I have a broken long bone and EMS asks me my pain level and I tell them it's a 10, what's the chances I'm going to get pain medication? Well, my chances are not good. Only 67% of patients overall meeting those criteria. Oh, by the way, ALS was also on scene. Only 67% of those patients actually received an analgesic in the pre-hospital environment. And there's a lot of factors that go into this. And our objective here is not to dive so much into those drivers, but to get agencies curious about looking at their own drivers. But one thing worth mentioning here is that these this treatment is not exactly equal. And we've seen this time and time again in the literature. And I know it can bring strong emotions because in EMS, we surely did not get into it for the fame and the fortune. We got into it because we like helping people and we like to help people the same. And that is our intention. However, there are systems in action here that give rise to disparate results. And so one of the things that we do look at is with a lens on equity, are we seeing disparities in pain management? And we certainly do see disparities here. And there is a peer-reviewed publication that goes along with it. So something that I would encourage agencies to do in some of the takeaways is, can you disaggregate your data and dare to take a look at, are we doing what we intend to do? Are we treating patients the same? And if we're not blaming people and calling them names, but changing our system so that we can get a different result.
Excellent. I'm going to pick you up on one thing that you said there, and maybe Dr. Myers can come in on this one, that you said if they care to document. Of course, documentation, getting it down there, the old, here comes a hackneyed EMS expression ready, everybody out there. If it isn't written down, it didn't happen. The importance of documentation, Dr. Myers, I mean, we all know the answer, but give us it.
Yeah, sure. And I think there's a nuance this year and in the very near future that's coming, right? So no doubt the notion that we are entering into the healthcare environment, we're going to be judged as other healthcare providers. There is a request to not only document, but document in the appropriate field so that the intention of what you want to do is also documented. That being said, just to look around the corner a little bit, over the next 12 to 24 months, I would be very surprised if we don't see a different method of documentation, more of an ambient listening, more of a, we'll listen to the conversation between the EMS provider and their patient, draw out the critical findings, and you'll be much more of a reviewer of what happened rather than a primary documenter of what happened. That will get us a much more accurate picture, but we're just not there quite yet, but we're very close and headed in that direction. But I do think it's really important. There's so many metrics that we could talk about that people don't hit the mark and they say, but I did it. Well, sure, you showed up at the trauma center. Here's a great example. Well, is that because it was the closest hospital, or is that because you went through the thought process and said this patient really needs to be at the trauma center? And there's really only one way for us to know that today, which is in a discrete field. I think tomorrow we'll be able to kind of have a much better idea of that. So it's not meant to be punitive or tedious, but rather to ensure that we know what your intent was, which is how we know that the metric was actually met.
Right. And that is sort of on the track to 2050. We know that AI is here. I was having a discussion where people are treating this like something that just turned up this year. Of course, if you think about the example I always love is, 15 years ago in the UK, we're doing a 12 lead. In the top corner of the strip, there was a suggested outcome to what it might be, which we were encouraged to put our thumb over and try and work it out for ourselves. But there was some degree of intelligence being applied even back then. The AI train has left the station now, and we've got to be on it and obviously embrace what's coming in terms of those adjuncts, I think, to help us practice in a much more efficient way.
Completely agree that the goal here is not to replace clinical decision making, right? The goal here is to remove tedium and to help you focus on the things that are important. And if, as long as the tool is doing that, I think it will be embraced by the industry. We just finished our WAVE conference last week, and that was probably the most common formal and informal question that I received was, yes, but the providers are not going to embrace this. And my response always was, if they don't embrace it, we haven't designed it correctly. This should be making their day easier, not harder. And as long as we do that, I think it will be embraced. And I think there's some really low-hanging fruit that you'll see in the near future.
You've taken me back 20 years to the UK where we couldn't take on electronic patient care records because, quote, old Barry couldn't type. So how things have come on. Metric 2, patients with suspected opioid overdose. We are living this. Everyone out there listening to this can immediately conjure up the scenario. But again, what do we find? What do you suggest?
So I'll set up the metric and we'll see what people think. But we were struggling 4 or 5 years ago. How do we reveal the magnitude of this in a way that is measurable over time so that we can trend what's actually going on? And so we landed on a fairly unique way of doing it, which is the percent of all EMS responses that are associated with opioid overdose by EMS impression. And the first year, it was 4 or 5 years ago, I think, the first year was 1.65% or so. We saw it sit there for a little bit, and then it crested 2% and even a little over 2%. And so I don't want to steal the thunder. I'll give it to Remle, but the way that we did that was so that hopefully one day when things start to get better, we would be able to see it in a trendable fashion. Because otherwise, if you just look at the number of calls, then there's all these different things you have to do. But if we do it as a proportion, then you can trend over time what's actually happening in the community. So that's the challenge. And this was, as Remle described, one of those surveillance metrics that we have in the index, just to kind of say, where are we in this particular patient type.
Yeah, and I think these surveillance metrics are really key to showing how EMS fits into the broader public health puzzle. Without these data, a lot of times we rely on the fatality database, on something like CDC's Wonder. And that's only telling part of the story, because with expanded access to things like naloxone, we're seeing a lot of non-fatal overdoses that otherwise potentially wouldn't be counted. And now with treatment in place, again, the EMS data is sometimes the only place to find this crucial component of the story. And thinking about how do we link patients to recovery resources, EMS is in one of the best positions to do so. And so something else we are monitoring the background on this is an emerging treatment called buprenorphine, which EMS is starting to perform in the field. And this edition of the EMS Index actually is being released around the same time later this month. Prehospital Emergency Care, a peer-reviewed publication, will be releasing a special issue focused entirely on advancing treatment for patients with opioid use disorder. And I had the privilege of serving as the special issue editor for that. But there's 30 articles coming out that are around, we're not as helpless as we may have felt. I think this type of encounter is very emotionally draining on EMS clinicians, because we see it over and over again, and we feel like we can't really do much to help that patient. And not only that, many of us also have personal experiences with opioid use disorder in our families, among our friends, or people we went to high school with. And so it's something that you just can't step away from. But I think that the treatments are advancing, and our understanding and our response models are advancing. And so there are a lot of innovations in this space and things in that insight section of this report that we should be paying attention to, and can give us some hope.
So it's interesting, actually, because before we started recording, Brent and I were talking about our various visits to the Big Hill in DC, and obviously this isn't a political webinar, but of course in this particular measure, there's a couple of political things that can either aid or not the situation. Of course, we are perhaps seeing a reduction in the import of these illegal herbs and spices, let's call it that. So that could be a good thing. But also we could see the reduction in funding for naloxone programs, which also could be a bad thing. So it'll be interesting in a year's time to see if there is any correlation in any of these things as well. So I mean, I'm looking forward to the 2026 edition to see if there's any effect, because as you quite rightly say, Remle, we know that our political colleagues now understand that we have live data 24/7, 365 to the tune of 50 million plus records, right? And so we have the information to turn into intelligence. So we'll see from your sample, actually, and again, I'm going to come back in a year's time, put it in the calendar, say, did you see anything then? One of the things about the report, of course, Remle, is the best practice section, and there are a number of best practice items within this one. But so to talk about how you structured the section, and obviously give us some of those best practice takeaways.
Right. And so our goal with best practices is, again, to provide some idea generation and get the conversation started. We don't pretend to sit behind our desks and come up with all of the solutions to any of these complex situations. But our goal is to provide, hey, here are some things that we have gathered from our partners in the industry and that we feel are worthwhile to share in case you should embark on an improvement journey and wish to implement some of these things. So one of the ones, for just as an example, out of the opioid section is use of the COWS score. Then that is not the animal, that is the clinical opiate withdrawal score, because when we are administering a medication like naloxone, one of our concerns is inducing withdrawal in that patient, which is an uncomfortable situation that often drives the potential for the patient to seek relief from that. And then we can see further overdose risk increase actually, instead of the converse being true, right? Which is what we're intending. So having the cows there, one, allows us to titrate our naloxone delivery so that we are avoiding the uncomfortable precipitated withdrawal as much as possible. But also, as programs like buprenorphine in the field emerge, the cows is a really important score for us to know whether or not that patient is eligible for this treatment, which is one of the best evidence-based treatments that we currently have available to us.
And I think it brings up a really good point. You know, we talked about that score is also obviously used when you use buprenorphine in the field,
right,
to give the objective results, which is an important piece for all of this. I think the really interesting part to me is we have seen, and I'd never use relative statistics, so I'm not going to here because we can make this a really great big number, but we went from 2 to 1% of the EMS calls associated with this particular disorder in 1 year. And that's awesome. The problem now is we want to go to the best practice. And as we should have, as a nation, we threw the kitchen sink at this, right? We changed prescribing practice. We made physicians look at a database. I had to take 8 hours of continuing education around this very particular topic to maintain my license, on and on and on and on. And so we don't know which one of these things has created the most bang for the buck. That's going to be part of the work going forward so that we can amplify the most important pieces of all of the things that we've done. But the good news is we've seen improvement. And so for now, we keep doing all of them until we can figure this out and amplify the ones that are the best. But the ability of EMS to Remle's point, survey the entire situation, not just those that are transported, not just those who unfortunately don't survive, but also look at objectively what we did is going to help inform that discussion going forward, because we can't let our foot off the gas at this point.
Excellent. Thank you. Let's move on to measure or metric 3, invasive airway confirmation using waveform capnography. Again, we've got a bit of a trend going here. Brent, so would you like to set us up?
Yeah, sure. So I will show my age. I remember when this paper came out. There was a paper that was published in Annals from Katz and his team in Florida. And it was controversial at the time, but it really made a really important point. If an EMS patient arrived in an emergency department with an advanced airway and end-tidal CO2 in a waveform was not being utilized, you could have displaced or dislodged or misplaced tubes, however you want to phrase it, up to 17% of the time. If end-tidal CO2 was in place in a waveform fashion, it was undetectable, right? The number was almost undetectable in this paper. And so this is just one of those, we can debate a lot of things, but we cannot debate the importance of waveform capnography for patients that have an advanced airway to ensure that it remains in place. And so this was a really simple measure. I will say this, back to our previous conversation about intentionality. For the purposes of the index, the provider, presumably an advanced life support provider because these are advanced airways, but we could have that discussion, but best provider had to affirmatively click the waveform box, right? Because we wanted the intention of, I am thinking about waveform and that's why we're going to use this. When we get to the discussion part, I'll tell you about us presenting this at WAVE. We got some really nice feedback, but that is the metric that you see. And so I think, people see the number and say that seems low, and we'll reflect on that in a moment. But that's the reason we set it up the way that we did, is this is a very known gold standard. We wanted to say, are you intentionally using the gold standard? And this is how you document that.
So I spent the first 10 years of my US life under Joseph P. Ornato as my medical director, and he swore by this. So I'm with you. Remle?
Yeah, so I also think it's worth calling out credit where it's due. So this measure is borrowed from the National EMS Quality Alliance, NEMSQA. And that's an organization that we partner with closely because their entire mission is to create evidence-based performance measures. And the evidence that you and Brent have cited on these published peer-reviewed publications leave no doubt that waveform capnography is a must-have when it comes to invasive airway placement. And Brent did mention, we will dive into this caveat on, we used a very specific field to ascertain whether or not waveform capnography was performed. And so there's a lot of pushback from the clinicians, which I think is actually a great thing. I love it when I get a phone call about these measures because it means somebody cared enough to look at it and to challenge it. And that's what we should be doing. But I'll give you the results overall on this, where out of almost 83,000 records with an advanced airway placed, only 64% of the time was that waveform capnography button clicked. And Brent, perhaps you can share a little bit about our experience being in front of a large number of EMS agencies last week. What was some of the feedback that we heard?
Yeah, so this is great. So to our point of the why we do the index in the first place, I was just barely had the slide on the screen and the computers opened and everyone was logging into their own tenant to see what their result was on this measure. So we had the intended effect. What came back was some really interesting feedback, which is, well, for us, we think digital is really waveform, so we use the digital button, which may be totally appropriate, and maybe that is what they're doing, and maybe, some information for us at ESO. Do we need to make these options more clear? Maybe we do. The other piece is, beyond the intentionality, is did it just happen, right? And so do we allow, if there is more than one and it's a waveform document coming in from a monitor, do you let you get credit for that, even if you didn't affirmatively say, I confirm this with waveform Untitled CO2, right? So all of that feedback came in, and then we had a nice huddle at the end. And the good news is, I think the actual measure, if we take out the intentionality and all the rest, our patients are getting this 95, 96% of the time. What this allows us to do then is have that conversation about how do we affirmatively document our intention, just like our trauma center example. Like, no, I didn't just put the monitor on and let it go. I actually looked at it, and that was how I intellectually affirmed if that tube was in the right place at all the different places along the way. So
Yeah,
great conversation, great metric.
and this one, because it's getting so much conversation, we've started a process at ESO called peak benchmarking, where in addition to what's in the index, we provide a deeper dive on agency level performance. And this is one where there is a lot of between agency variation. So some agencies are hitting it 100% of the time, but some agencies are not hitting it at all. And that opens up questions about resources and thinking through protocolization. So if I'm a BLS agency with supraglottics, in some states, capnography is not included in the scope of practice, perhaps. And so that's something for us to question is, if I'm going to be performing an advanced airway, I should make sure that Untitled is available at all levels that are going to be placing those advanced airways.
Great. Well, that was the first three of our metrics up for discussion. When we come back, we'll carry on. But for the moment, a quick word from our sponsor.
Lexipol empowers first responders and public servants to best meet the needs of their residents safely and responsibly. Serving more than 2 million public safety and government professionals in over 8,000 agencies and municipalities, Lexipol offers a range of solutions that includes policies, training, behavioral health resources, news and analysis, and grant assistance services for law enforcement, fire and rescue, EMS, local government, and other agencies dedicated to public safety. To learn more, visit lexipol.com. That's LEXIPOL.com.
And we're back. So please make sure that you like and subscribe on the platform wherever you get your podcast or your vodcast from. Remember, we are on Apple Podcasts, on everywhere else, on audio. We're also on the EMS One YouTube channel, so you can see us, you can hear us, and also you can enjoy the graphics, charts, and graphs that we put on our vodcasts. And as I keep telling everybody, this is the webinar you didn't know you needed. Here we are with it, talking to Dr. Brent Myers, Dr. Remle Crowe about the ESO Index. Let's jump straight back in with the next measure, which is obstetric emergencies. Brent?
Yeah, so this one was an eye-opener for me as well, and I think we also had a discussion with many medical directors around this particular metric. So there's two components here, both of which are now in an evidence-based realm, one of which is in an EMS evidence-based realm that began 3 weeks ago. So I think we're right at the time that we want to talk about that. So the first of those is looking at the availability and utilization of Pitocin and or TXA in a patient that's experiencing postpartum hemorrhage. This is and both of these OB/GYN measures, I think, speak as much to protocol and availability of medication as they do to the individual provider's choice of what to do. And I like to draw the distinction between this metric and the pain control metric. It's extraordinarily rare for pain control not to be available to an ALS provider, right, in the back of the ambulance. So that is an individual provider interpreting the protocol, determining when it's time to do something. Compare that to this metric, which is why I actually am thrilled that it's in here, because it allows the industry to have a second type of conversation, which is what materials should be available on every ambulance and then available to every medic. And then and only then can we come back and say, well, is there a disparity in care here? Because we're not sure today all of the equipment that's on the ambulances. So there should be, it appears, Pitocin on the ambulances. That'd be a great national discussion. There are others that will come back and say, well, it expires on the shelf. And I come back and say, well, it doesn't cost anything because it's generic. So what difference does it make? This needs to be available. You know, we can have the fun discussions to have, right? But the indication.
I'm glad you said that, because of course on this show I've been known to be the curmudgeon EMS chief with the classic line, well, who the hell's paying for that then? So I'm glad you mentioned that.
Yeah, right. And is this, is this fall into that same category as blood and other things where it's on supervisor vehicles? Yeah, we can have this discussion. But the patient need, I think, is one of the neat parts of our outcome metric here, because even though in-field delivery is relatively rare, not to steal the thunder of it, we'll talk about whether they got treatment or not, but 15% of the in-field deliveries had a documentation of postpartum hemorrhage. Now, the degree of that hemorrhage is not attainable from the way we document, but it's not as if this problem doesn't exist, right? So we have to think about that. And then for anybody that's been practicing for any period of time, right, you're going to come back and say, well, there's a patient beyond 20 weeks to 6 weeks postpartum. They have hypertension. Now, which of the signs or symptoms do they have to indicate that I should give them magnesium? And that's what I think a lot of us are very comfortable with, because that's the way the practice pattern and the guidelines have been. 2 years ago, the inpatient guidelines changed, and there are firm rules about blood pressure alone in the absence of any other symptoms that indicate treatment is necessary. Those guidelines came from NAMSP, ACEP, and others 2 weeks ago, a week and a half ago, that emphasized EMS needs to be doing the same. And so this is a really kind of truly late-breaking national conversation, because the medications that are indicated are not commonly administered by EMS, right? So if we think about this, and we look through the data collaborative just to see, by the way, one of those is sublingual nifedipine, hadn't been administered in the field at all in the past 5 years. One of those was hydralazine, it had been administered 5 times, I think. I may have those backwards, but at any rate, one of them was 0 and one of them was 5. And then out of the millions of records, labetalol had been given about 2,000 times. About 200 of those times were to patients between 20 weeks gestation and 6 weeks postpartum. So 3 medications, not very commonly used, one of which needs to be administered to this patient population. How do we as an industry handle these clear evidence-based recommendations in the face of what we currently have on the unit? And so that's why this metric is in there. And Remle would be the first to tell you, we had a lively debate internally because the EMS guidelines were not yet out when we first started looking at these numbers. I'm like, nobody's going to care about this. That's not what the guidelines read. And lo and behold, the guidelines tell us something different.
Wonderful. Remle, best practices.
Yeah. So, and again, I want to highlight that this one is not passing judgment on an EMS system of you should have done X, Y, or Z. This is really the baseline, given that we have these new guidelines from the American College of Obstetricians and Gynecologists really saying, hey, in the EMS space, we have a unique opportunity to make a big difference here. So, one of my key takeaways is that hypertension is very common. Over 1 out of 10 patients had documented hypertension meeting that severe threshold that Brent mentioned, where we should consider treating even in the absence of any additional signs or symptoms. And then with potential for postpartum hemorrhage, this is as we have longer transport times, as we experience systems concerns like maternal care deserts, we really should be prepared to treat this and have the system conversation around how are we going to do this. So as far as a best practice on this one, this is not to pass judgment and say thou shalt do whatever. It's let's evaluate our system. Now's a really good chance to do that and say what should we have in our toolkit and how should we be delivering this in a way that's going to be equitable. And so reevaluating our protocols in light of the new clinical guidelines would be one of those largest recommendations, is to say, hey, are my protocols in alignment with the best evidence today?
Great. Before we go on to the next metric, which by the way is pre-hospital whole blood surveillance, just take a second to go back one edition of EMS One-Stop, where last week my guests were Dr. Matt Levy and Dr. Christine Carrico, talking about their recently published academic paper looking at some of the barriers to the delivery of whole blood. We had a great conversation. Actually, we've had some amazing, it's only been a few days since it's been published, some amazing reactions to that paper, all the way from some government departments who I won't mention, but even so, there's a lot of interest in this. So clearly there's going to be a lot of interest in this section too. So pre-hospital whole blood surveillance. Now I've set you up, Brent, off you go.
No, thanks. And, so to give the backdrop here, right, we know that from very solid military literature that giving whole blood to a patient who's had penetrating trauma, who has a alarming shock index or a systolic less than 90, however you want to parse out somebody that's at risk, dramatically impacts outcome. And it's time to whole blood, right, is the answer to the question. And the only way to have that for patients with penetrating trauma nearly everywhere in the military theater, and as it turns out in the civilian theater as well, is to have it available in the out-of-hospital environment from EMS. So that evidence is strong. And to your point, the question now becomes, how do we do this in a way that doesn't impact the blood supply, so forth and so on? What we found anecdotally through other smaller projects over the past year and a half, however, is that a significant proportion of the blood that is being administered in the out-of-hospital environment is not being administered for trauma patients, and certainly not being administered for penetrating trauma patients, but there's blunt trauma patients, and there's also medical patients, the vast majority of which are gastrointestinal hemorrhage, some of which is actually vaginal bleeding, right? So there's those extremes on the medical piece. This may be incredibly beneficial, or it may not help at all, because we just don't have the evidence about the medical component in the out-of-hospital environment. And it is a different physiologic construct, right? If you were shot in the chest and your blood pressure falls and you have a large amount of blood in the field, then that's not a complex clinical diagnosis. However, if you vomit a large amount of blood, we don't know how acute that is. And did you vagal down? All of the different things that could happen. So I'm not saying it's inappropriately being administered. What I am saying is that we wanted to shed light on this so that as we evaluate out-of-hospital whole blood, we're thinking about not the narrow use case for which it originally made it into the field, but we think about how it's actually being used today and look at the appropriateness of that administration or utilization. So that was the reasoning for the metric. Is you'll see we focused on the indication for the administration, and that's the reason that we did it that way.
And then, so with the takeaways on this, again, as a surveillance measure, the takeaways are more centered on programmatic considerations. So as more agencies are implementing the use of pre-hospital whole blood, it is important to keep a few things in mind. One of those being no drop of blood gets wasted. And so having protocols for, we rotate out the blood after 14 days because it has a shelf life of about 21 days, having that relationship with the blood bank so that we don't waste any. Also having donor programs. It is common for the EMS agencies to perform donations in order to be able to sustain this, because we don't want to run out of blood from those blood banks with such a precious resource. Making sure we're using it per protocol and not that it's something shiny and that I just want to use it. Using it really, really intentionally is a key aspect of this. And then the data component of this is important. And something we focused on heavily at ESO is how do we make sure that we have those required elements that we're going to need to turn into the blood bank, and can we automatically transfer those ahead of time to the hospital? So that's something we've built out to look at things like the lot number on the bag, the start and the stop time, and what kind of blood was the donor, what kind of blood was the recipient. All of those things are really key data aspects that we can facilitate, and it is a great time to be in data, because before this was going to be on a tiny sheet of paper that would have had to been physically carried over after the blood was administered.
Yeah, and I think, where this needs to be utilized is going to be the really interesting piece. There's that, the similar thing that we hear about other things. Oh, it's an urban center. They're close to the trauma center. Why would they need to do this? And I think we have to look at the time to blood administration, not the time to hospital arrival, right? And there's, my hometown in Wilkes County, North Carolina, in the northwest corner, relatively rural area, long run, probably 50 minutes, an hour to get to a level 1 trauma center. They carry blood on the supervisor vehicle. They have been able to do so for a long period of time with zero wastage of the blood, right? The the ability to bring it from the trauma center. If you use it within 2 weeks, great. If not, you send it back and it gets priority to be utilized there. And so there is no wastage of the blood. And it appears, right at first pass, that all of the indications and utilizations that have occurred are right down the line of the protocol. So it can be done, and it doesn't have to be in an urban center. I think the healthy debate for the next year is going to be, where is the right place for this to be? And maybe it is community specific, but it does appear that there's a benefit that is conferred.
So let me ask a Remle question then. So Remle, your next blood research project, what are you going to call it, and what's it going to prove in the end based on what Brent's just said?
Oh, well, we have other partners who are taking on some of this research. And actually, this is a good time to mention that we've partnered with the Prehospital Care Research Forum to host research workshops for those frontline clinicians who are interested in research, but might be intimidated because, well, I don't do statistics or whatever might be holding you back. We remove those barriers and make it possible for you to come and ask and answer questions with this data set. We provide the clinical mentor and the statistician. And in fact, at the last research forum, a group took on a question about pre-hospital blood and split it out by trauma and medical. And I won't spoil their results because it is actively under review at a peer review journal right now. But I think it's a great opportunity to continue to ask other questions. And I encourage, it is so important to have the frontline EMS clinicians participate in research. It makes for better projects that reflect the setting where the data were collected. So that's just my plug to participate. If you have even an inkling of curiosity into research, participate in one of these research workshops.
Well, I'm glad I asked the question. I absolutely loved your answer. So thank you for that. And we'll put some links into, there is a number of initiatives and programs actually coming up. Pre-Hospital Research Forum. We know that the NAMSP year-long research class, I know they're already now seeking the next cohort. So there's a number of programs, and obviously there's the Williams and Taigman class, we'll call it that for the minute, that are running as well. So your opportunity to learn about and participate in research is very, very real right now. And so I'll put some links in the show notes, everybody out there, for that. Behavioral health in pediatric populations. To me, it's a sad one.
Yeah, it is. And I think, one of the things that we've been called upon here to kind of, give an already an area for improvement is to trend this over time, right? But what we see now is this notion of the mental health of patients, particularly those between 13 and 17, and the overwhelming proportion of calls that are related to behavioral health and substance abuse. And so the issue is, how do we deal with this and how do we get here, right? And what we are seeing is, and we have a state project that'll be presented in SIMSO that I can't talk about yet either, but this notion of, is this post-COVID? That has been the biggest question that we've had. The hallway conversation at WAVE was the patients that are in this age group now were not in a normal environment, in a classroom, socializing with their peers in a very important developmental time. And post that time, we have the social isolation that comes from social media and all the rest. I'm not getting all the political sides of all that, but it was interesting how the conversations were the same spontaneously all up and down the hall about, is this unusual? So I think the first question that we're going to have to answer is, use this methodology and trend this over time, which is not the purpose of the index today, but we need to think about that. But the goal here was to call attention to something that organically came up to us from our state partners, from some of our larger EMS agency partners. Say, we're seeing a thing. Is that what you're seeing? Is that the national scene? And so that was the impetus to do this. Now that we have this finding, we've got a call to action.
Right. And what we're seeing here is that, again, these types of responses are very common. So it's 1 out of every 8 pediatric EMS encounters involves a behavioral health or potential substance use disorder component. So it's something that as EMS systems, designing our continuing education or designing our systems on, do we have a good relationship with a pediatric behavioral health center? Do we have places to go? And if we don't, can we go to our local government organizations and advocate on behalf of our patients that we have this community need that EMS tends to fill, and that emergency department is not the right resource for every patient and can actually be a traumatic experience in some cases. And in line with that, also, some of the tools that we should have in our toolbox are behavioral screening instruments. I know that it seems wild to me. Every year we train in CPR and we do our first aid certifications. But I actually received one of the best EMS trainings of my life, not in EMS. I was an adjunct professor of statistics at a community college, and they trained me in mental health first aid. And I thought, this is so incredibly helpful and will undoubtedly help me with my patients in the field. Why is that not something that we're incorporating into our EMS training, particularly given how often we are seeing patients who are experiencing these behavioral concerns?
Well, you've just given me an idea for the next webinar and podcast, Remle. So thank you for that. Sorry, Brent, do go on.
No, that's okay. I think the other, our team at ESO is called the RPI team internally, which is Research and Performance Improvement, right? Is what that stands for. It gets made into all kinds of pi symbols and all the rest. But the performance improvement part of that, just to prove, even at my advanced stage in this industry, substance use disorder does not fall off my tongue. Substance abuse does. And so the notion of speaking of a process in its truest term is part of what we're trying to do. So I realized the minute that I said it wrong, and I couldn't figure out how to back out of it. So I think we ought to just say it, right? That it is a use disorder. It is not abuse. That term is going to stick, unfortunately, for a while because it was in the zeitgeist for so long. But I think it is important for us to call it by its name, so to speak. And that's part of the performance improvement, is to have a definition and stick by it. So I wanted to correct myself. And so thank you for the opportunity to do that.
Wonderful. Thank you. Last and probably not least, probably almost foremost in some of the providers out there on the street, and everyone has a story, I know, high utilization group. We live this, I'm afraid, but talk about what you found.
So this is one of those not unintended consequences, but I think the magnitude of what we found was unintended. Where this began is, and we're not selling ESO products here, but just to talk about how we got here, is within the software, there was an opportunity to look back 150 days if you'd seen that patient and get a little information. And people were saying, no, I need a much broader view. To your point, I need to get ready to talk to my watch and have everything come down. So we spent a great deal of engineering time creating, we meaning the engineers, clearly not me, creating a longitudinal record, meaning that we could not look episodically, but that we could look across a patient. And from there, the RPI team looked at that and said, well, wait a minute, why don't we evaluate the entire data collaborative in a couple of pieces of this to see, number one, how often does patients call? And folks at ESO know that I've said this forever, which is, it is preposterous to me that 9.5% of the population has a time-critical medical emergency every year. But if you take your NEMSIS number, then we're somewhere between 9.5% and 11% of the population calling every year. That's not actually what happens, and that's what we'll find out in just a moment. The other is, as a medical director, I was always concerned about the patient that was left behind. And if you listen to the anecdote, every time somebody was left behind, they're going to call back within 72 hours and CPR is going to be in progress. And oh my God, you missed something. And so because we were living in anecdotes in both of those worlds, right? Those who call us frequently and those that we leave behind, our policy and fear was informed by anecdote. We were now able to change that and inform it by data. And so the purposes of this was just to say, now that we know this longitudinal record, indeed, how often do people call? And what does that look like over frequency of call? And number two, if you don't, or if you do, transport somebody to the hospital, what's the likelihood they're going to call EMS back within 72 hours? So that was the metric. And the last thing to say is the 72-hour metric. There's nothing magic about that. That's a general metric from the emergency department. If you return to the emergency department within 72 hours, those are supposed to be reviewed. That has about the same evidence as 6 versus 12 of adenosine, which we could talk about later. But 72 is a nice spot. You can move it, but that's what we chose to do the reporting.
Absolutely. And some of the key takeaways here are, first of all, this patient masked ID allows us to first drill into how many unique incidents were there, because it's common to send more than one apparatus to a scene, and per our response models, that makes complete sense. But when it comes to the EPCRs, we're generating unique EPCRs, and so we may be overcounting incidents. And so that's one of the first findings in this index is out of the 12 million or so records, really there's almost 8 million unique incidents after deduplicating. And then when we deduplicate patients, out of those 7.7 million, we've got about 5.4 million unique patients, meaning that 1 out of 5 patients is going to utilize EMS more than once in a calendar year. And so we should be prepared to study and understand what are the resources that make sense for that group. But there's this high utilization group, and we try to stay away from frequent flyer. It's another one. Brent mentioned words matter. It's another one that's just derogatory and not professional. And so we've leaned towards high utilization group. Hug sounds way nicer and really reflects. These are generally pretty sick patients. When we were drilling into them for some of our research, it's not always that patient that you think of that's abusing the system, so to speak. And there were air quotes there for those who are on the audio only version of this. There's a reason they're calling, whether or not it's the medical emergency, and we should be sensitive to that. But there are 6% of patients who are utilizing EMS very frequently. And in fact, that 6% of patients makes up 20% of those calls. And so this is something for us as EMS systems to plan for and focus on, and potentially dedicate a resource that's right for that patient. That, hey, these are medically complex patients who are going to require potentially a different set of resources than traditional EMS call, transport to the emergency department, release, EMS call, transport to the emergency department.
So mixing and matching Rob's social media outlets, Jared Troutman told me on the escalator that, the fact that everybody calls 911 for a reason, but we're not actually equipped right now to deal with all of those reasons. And that's the point that you make there.
Yeah, I think the other way of looking at these data, which I think is fascinating, Remle's right, 80% of the people only call EMS once a year, but that only constitutes 56% of EMS responses. Said another way, 44% of the time an ambulance rolls, it is going to see someone who's called EMS at least once in the previous 365 days. And so I think when you think about response patterns, you think about, again, what's available. Do those patients necessarily need the same time critical emergency response that some others, or do they need a different type of response? To everybody's point, they are calling for something, and we should honor that. We should just be able to better match the needs of the patients with the resources we're sending.
Fantastic. As we come to the end, obviously you came up with some recommendations and sort of conclusions. And so I'll turn that into my sort of Rob ending question. Okay. Is there anything I've forgotten to ask or anything you need to tell us, but tell us about your conclusions.
So I think the most important part of this document is that it focuses a conversation on key components of our industry. And whether your system is 2% above or 2% below is rather not the point. But the point is, can we as an industry agree these are important? And we're not in any way trying to compete with NEMSQA or others. This is just a conversation starter plus. And as long as we get to that point, then I think we're having a conversation about something besides response time, which means we're probably in a pretty good spot.
And for me, the biggest thing here is the call to action. It's an interesting document to read and see, but it serves no purpose if we're not going to use it to improve community health and safety. And so I urge organizations, and we make this freely available to everybody. This is not an ESO specific document. So I would encourage anyone in the industry to go to Rob's show notes, click the link, check out the data, and run this in your own data set. Because we have a national data standard, anybody can look at these metrics. and to just take one small action towards improvement. I think we get the analysis paralysis, or we think we have to roll out everything super huge all at once, but really there are small steps we can take today. Can I review my obstetric emergency protocols right now? Can I disaggregate my data today? That's a huge one, is building equity just into our regular daily practice and not being afraid to look at the stratified measure and to take action if needed.
So actually, this comes back to the data, my favorite four-letter word analogy, right? So this week I have been in Sacramento. I've been giving evidence at a committee in order to get a bill through. And in order to make my statements, I've been rattling a piece of paper with data on it, with research, with absolute fact, which takes, back in the day, a great American phrase, by the way, back in the day, we'd just have the I feel, I think, my gut reaction is. Now I've got the piece of paper with the peer review or the absolute information on it that I can say, here's the proof in the pudding in order to generate the change that we need to make. So, and this report will help us do that because it's laid out in such a way that even my friends on certain hills will be able to understand. So thank you for doing that. But again, thank you both for joining me. It's an amazing document. It's exceptionally well laid out. It is exceptionally easy to understand. The takeaways are superb, and I commend that everybody, as Remle's already said, it's free. Download it, read it, and act on it. So Brent and Remle, thank you very, very much for joining us on this edition of EMS One-Stop.
Thank you for having us.
Thanks for having us.
So there we go. That was Dr. Brent Myers and Dr. Remle Crowe. We didn't use the word taco once. There you go. I'm contractually obliged to use that. Do join us again next time round for another edition of EMS One-Stop. That was the EMSO Index. Please read it. Also, please like and subscribe. So until next time, thank you to Brent and Remle. I've been Rob Lawrence. And until next time, bye for now.